Next to Dr. Graylow is Dr. Clifford Hudis, his formal name, Chief of Breast Cancer Medicine Service at Memorial Sloan-Kettering Cancer Center in New York City. Hi, Dr. Hudis.
Hello, nice to be here again. I'm going to start by providing the background on this, and then I'll get to some of the data that's being presented today so that it's not only about new data here, but where we came from. The dream that shutting off the signaling that causes or allows tumors to grow blood vessels began many years ago. And the very simple model is that in order for a tumor to grow above a certain size, it needs nourishment. And for that nourishment to efficiently reach the tumor needs blood vessels. That's called angiogenesis. And we've tried to inhibit that with, of course, angiogenesis inhibitors. The first generation that made it to the clinic was a monoclonal antibody called bevacizumab. You know it as the brand name Avastin. As a single agent given to women with metastatic breast cancer, there were a few responses, meaning cancers got smaller in a few people, but by and large it was not what we would call an impressive drug. The second trial, the big trial that first came to everybody's attention, was in the metastatic setting where the conventional chemotherapy drug capecitabine, known as Xeloda, was given alone or with bevacizumab, and in fact that study was called a failure by the investigators. It did not show an advantage for the drug combination. And then things were quiet for a long time while the Eastern Cooperative Oncology Group, ECOG, performed a randomized trial in the US. This turned out to be a controversial trial because this study of paclitaxel as first chemotherapy for metastatic disease alone or with bevacizumab ended up identifying probably the largest improvement in progression-free survival that we had ever seen in the metastatic setting. Roughly 6 months became roughly 11 and a half. Now, it's important to pause for a moment for everybody to be brought up to speed. When drugs get approved in the United States, they are generally approved because they offer a clear benefit compared to the risk that they bring. And the way we test that benefit, ideally, is we show that survival in an incurable disease is improved. That can take a long time, so for several decades now, the FDA and others have relied on a surrogate of survival, meaning an early indicator of what the ultimate survival would be so we can get our study results earlier. We used to use just response rate, how often did the tumor shrink, and then we switched in many settings to using progression-free survival. I mention all of this because the dilemma that the ECOG study presented was this big improvement in progression-free survival was not matched by any measurable improvement in overall survival. So that raised almost existential questions about when a drug should be used, especially if it's expensive, and what the trade-offs really are. The third study that came in was the Avada Study, which was similar in design with two differences. It was docetaxel, a different taxane called Taxotere, and it was placebo-controlled, so the patients in that trial did not know whether they were getting bevacizumab or not. The ECOG study was unblinded. And the benefit of bevacizumab in that trial was really quite modest, measured in the difference of about a month or two, and again, no difference in survival. At ASCO, we saw the so-called Ribbon 1 trial, which was an interesting study, very real world, where doctors could choose one of a menu of chemotherapy drugs and give those drugs alone or with the bevacizumab, placebo-controlled, same result. Very small but measurable improvement in progression-free survival. And at this meeting, we will get Ribbon 2, which is the same design for more heavily pretreated patients, and the result will not be a surprise to anybody here. So the problem is we have this exciting science, well worked out. We have thousands now of patients randomized, and we do not show an improvement in survival. And many of our colleagues will say, well, it's very hard to show survival differences in metastatic breast cancer, but as you'll hear in a moment from other speakers, in fact, with some drugs, we very quickly show survival differences. And I don't believe that it's impossible to change survival at all. So that's the background on the field. Now, the way that bevacizumab works is that it targets a circulating factor called VEGF, vascular endothelial growth factor. And essentially, you could think of it as a tight sieve pulling the VEGF out of the circulation. If it's gone, the VEGF receptor is left naked and doesn't signal, meaning blood vessels don't form. What's new at this meeting is the results of two randomized trials testing small molecules that also inhibit the VEGF receptor, but they work very differently from bevacizumab. They don't work by attacking the VEGF itself. They work by shutting down the receptor, much akin to the way you think of lapatinib as shutting off HER2, the receptor. And the first of these studies actually was a study with the drug sunitinib, which was the first of these to make it to clinic. And the results there have been, I'd say, somewhat disappointing. But the big news has been with another drug in that class called Sarathy Nib, and I know that Jose will talk about this. I'll just, by way of introduction, say that his trial, which was a randomized trial of capecitabine alone or with Sarathy Nib, actually showed a significant advantage, which he'll expand on. A second trial that Bill Gradishar is presenting at this meeting of Sarathy Nib and paclitaxel, to be very precise, is consistent with a benefit for Sarathy Nib, but standing alone does not prove or confirm it. And that's the nature of this small randomized trial. An important third trial, which I'm just mentioning here because we want to finish it, is one that I'm running with either gemcitabine or capecitabine. The distinction being it's for patients who've had disease that has grown on bevacizumab. So we're asking whether after bevacizumab we can again salvage a response with a small molecule inhibitor. So that's a lot, I know, but it lays out what I think is the entirety of the field right now in breast cancer. And the next step, which is a really important one that your audience will want to watch for, is that we are almost finished several randomized trials of bevacizumab in the early adjuvant setting. And picking up on something that Ken Osborne mentioned, it's very possible that a drug with modest but consistent activity in the metastatic setting could have a profound impact in the adjuvant setting by preventing the seeding of tumors into the bone and other tissues, as we've talked about. So this is really exciting translational science that's unfolding at this meeting.